Welcome to this interactive case study. This is Charles. Charles is a 56-year-old. He was diagnosed with type 2 diabetes last year. He was born in Barbados, as were both of his parents, and they all moved to the UK 50 years ago. Charles lives alone and is a taxi driver. Charles is booked for a follow-up telephone consultation by his practice pharmacist, Ajay, to review his diabetes. Whilst on the call, Ajay asks how Charles is feeling. Charles is fine, but he often feels tired and is disappointed that he hasn't managed to lose any weight. Ajay checks his current medications. Charles takes metformin 500 mg twice a day and amlodipine 5 mg once a day. Ajay then checks his recent blood results. Total cholesterol is 5.5. Hemoglobin A1C has come down from 73 6 months ago to 65, which is 8.1%. His estimated eGFR, which is the glomerular filtration rate, is 87 and should be multiplied by 1.21 as he is African Caribbean. His ACR is 7 mg per millimole. Charles's blood pressure was 147/94, which was an average of 1 week's home readings. Charles's calculated BMI is 36 and his Q risk is 39. Ajay takes a moment to think. What are my goals of care? 1, to prevent complications, and 2, to optimize Charles's quality of life. What complications is Charles at risk of? Charles is at high risk of cardiovascular disease and his kidneys are showing early signs of deterioration. His ACR suggests A2 and eGFR G2, indicating moderate risk of CKD. He's also at risk of retinopathy and neuropathy, and he's predisposed to erectile dysfunction and depression. Ajay aims to share the treatment decision-making process with Charles. They discuss how to reduce his risk of these adverse outcomes by maintaining healthy blood pressure, cholesterol, and glucose levels. Ajay asks Charles how he takes his medication, and he says he takes everything in the morning before breakfast. Charles is currently not taking the maximum doses of either his metformin or his calcium channel blocker. He agrees it would be best to optimize these medications, and they're both increased to metformin 1 gram twice a day and amlodipine 10 mg once a day. They discussed the benefits of lowering cholesterol levels to further reduce complications. Charles agrees to take a statin and is commenced on atorvastatin 20 mg a day. Ajay explains to Charles how vitally important it is to manage blood glucose levels really well, especially in this early stage, ensuring a beneficial legacy effect. He reinforces the benefits of eating a healthy diet and becoming more physically active. Ajay explains that when aiming to prevent complications and optimize quality of life, there are 2 medications to add to metformin that would be of particular benefit. Number 1, an SGLT2 inhibitor, which would have had a beneficial effect on Charles's blood pressure and glucose levels and protect his heart and kidneys, and also help with weight loss. Number 2, a GLP receptor agonist, which has a similar benefit, and it's available in a weekly injection or a daily tablet. As Charles does not have established atherosclerotic cardiovascular disease or chronic kidney disease, Ajay follows the without established ASCVD or CKD route on the flowchart. Charles has a compelling need to minimize weight gain and promote weight loss. Therefore, we are advised to choose a GLP-1 with good weight loss efficacy or an SGLT2 inhibitor. Together, they discuss the pros and cons of both these options. Charles is happy that they will protect him. He's going to consider which one he'd like to start and books up a follow-up call in 2 weeks' time to confirm this. Ajay says it's really better not to delay this.
Hi and welcome to Considering Culture in Diabetes Care. Over the last 2 decades, England has become more ethnically diverse. Black, Asian and other minority ethnic groups make up a large proportion of the population. With these changes in the population, it's becoming clear that certain health conditions have an increased prevalence in BAME communities. In this short learning module, we'll specifically look at type 2 diabetes, cardiovascular disease and COVID-19, and the links between each. Evidence suggests that there are a number of barriers to people from BAME groups accessing local health and mental health care services, and NICE Quality Standards says that more needs to be done to ensure BAME communities have a voice in local health and well-being services. Let's start by thinking about ethnicity and type 2 diabetes risk. The South Asian population living in the UK are up to 6 times more likely to develop type 2 diabetes than that of the white population. People of African and African Caribbean descent are 3 times more likely to have type 2 diabetes than the white population. Uncontrolled diabetes can lead to associated health problems, affecting almost every organ in the body and potentially leading to heart disease, stroke, impaired vision, renal failure, painful neuropathy and foot problems. In the UK, there are over 500,000 people from BAME communities living with diabetes. All have increased risk of developing these complications. People with diabetes have about twice the risk of developing a range of cardiovascular diseases compared to those without diabetes. Data from the National Diabetes Audit shows that there is a 138% increased risk of angina, a 94% increased risk of myocardial infarction, a 126% increased risk of heart failure, and a 62% increased risk of stroke among people with diabetes. There are even higher rates of cardiovascular disease in BAME groups. Heart attack rates are higher among South Asian people and they occur at an earlier age. Death rates from cardiovascular disease are approximately 50% higher. Q-Risk3 is a validated and widely used risk assessment tool, but all people living with diabetes should be considered high risk of cardiovascular disease. The Public Health England report from 2020 states that people from Black ethnic groups are more likely to be diagnosed with COVID-19 than any other ethnicity. Death rates from COVID-19 were highest among people of Black and Asian ethnic groups. People of other ethnicities had between a 10 and 50% higher risk of death when compared to white British. A government review has concluded that most of the increased risk of infection and death from COVID-19 among people from these ethnicities is explained by factors such as occupation, where people live, household composition, and pre-existing health conditions. People with diabetes and or other long-term health conditions are more likely to experience symptoms of greater severity, and the risk appears to increase in people over the age of 70, particularly those with comorbid heart disease, diabetes or respiratory disease. A mere glance at this excerpt from the COVID-19 risk assessment tool will highlight the risk factors shared by COVID, cardiovascular disease and diabetes and obesity. There are multi-directional links between all of them. So let's think about these risk factors and what can be done to prevent or lessen the effects of these diseases in people from BAME communities. Firstly, BMI. There's a great BMI calculator on the NHS website. It asks for height and weight in kilograms or in centimetres or in feet or stones, but it also asks for activity levels, ethnicity and gender, so it's calculated more accurately. It then gives the user advice where to get help from and whether people need to see their GP. On the right, you can see the BMI classifications. NICE guidance says that we should interpret BMI with caution because it's not a direct measure of adiposity. They suggest using waist circumference in addition to BMI in people with a BMI less than 35. For Black, Asian and minority ethnic groups, the NICE and the World Health Organization traditional cutoff points are not appropriate. BAME populations face the burden of disease at lower thresholds, being at an increased risk of metabolic disease with a BMI of 23 or higher, and at high risk with a BMI of 27 or over. Similarly, at-risk waist measurements are 94 centimetres or more for men, except those of South Asian origin who are at risk at over 89 centimetres and 80 centimetres or more for all women. So NICE guidance says that regardless of height or BMI, try to lose weight if waist is 94 centimetres or more for men, 80 centimetres or more for women, and the very high risk and should see GP if waist is 102 centimetres or more for men and 88 centimetres or more for women. So visceral fat, i.e. fat around the middle, is much more metabolically active than in other areas of the body. Visceral fat produces cytokines and hormones that have a detrimental effect on blood vessels, increasing insulin resistance and increasing risk of micro and macrovascular changes. So we can calculate someone's risk of adverse events according to their waist measurements. So in order to reduce risk then, we need to reduce wastes. Weight loss where necessary helps everything, including blood pressure, cholesterol and glucose levels. 10 kilograms of weight loss can achieve a 50% reduction in blood glucose. It can improve blood pressure, systolic by 10 millimeters of mercury and diastolic by 20 millimeters of mercury, and can improve cholesterol. Total cholesterol by 10%, LDL by 15%, triglycerides by 30%, and HDL rises by 8%. But 10 kilograms is a lot to lose. So even losing 5 kilograms of weight can reduce cardiovascular disease risk by 30%. That's good news. There's no best way to lose weight, which is why dietitians work to understand personal circumstances when making recommendations. When aiming to lose weight, it's important to have realistic goals that are achievable. Success boosts confidence in people's ability to lose weight. A weight loss of 0.5 to 1 kilogram a week is usually a realistic target. People who successfully lose weight and keep it off develop techniques to make their new lifestyle and activity habits an enjoyable way of life. Most South Asian diets are high in carbohydrates such as rice, naan, chapatis, potatoes, and carbs typically amount to about 60% of the diet. Helping people understand how carbs impact their blood glucose and how to alter portion sizes and food choices is key to taking control of their diet and their diabetes. For more about Asian diets, why not listen to our discussion? And here's a few more top tips for your patients. Exercise or activity is an equally important lifestyle factor in improving and preventing diabetes and cardiovascular disease. Any type or amount of physical activity will have health benefits. A wide range of physical activities like walking, gardening, jogging and yoga can significantly reduce HbA1c. And most importantly, encourage a reduction in sitting time or a breaking up of sitting time. And a combination of dietary change for weight reduction and physical exercise improves hyperglycemia and reduces cardiovascular risk factors more than dietary interventions or physical activity alone. Fasting is practiced in many religions. It's not always advisable for people living with diabetes. Anyone who is putting their health at serious risk by fasting is usually exempt. For example, people who treat their diabetes with insulin, or people who have complications such as sight loss, kidney or nerve damage to the hands or feet. For people who still choose to fast, there's plenty of helpful advice on the Diabetes UK website, and there's great resources available such as Safer Ramadan on the Eden and Leicester Diabetes Centre websites. People should speak to their healthcare team if they're planning to fast. But this slide shows some general advice. Vitally important in reducing risk is maintaining a healthy blood pressure. This applies to everyone and especially people living with diabetes. 74% of people with diabetes have hypertension. NICE guidance advises us to treat all people living with type 2 diabetes and hypertension with an ACE inhibitor or an ARB. For people of Black African or African Caribbean family origin, it's a calcium channel blocker first to begin with, and then an ACE or an ARB or thiazide-like diuretic. To sum up then, we as healthcare professionals must keep in mind the increased risk of diabetes, its associated complications and cardiovascular disease in our patients from BAME communities. This should spur us on to choose diabetes medications that have cardiovascular benefit. If they help to protect the renal system and lower weight and blood pressure, that's even better. And we need to introduce these agents sooner rather than later. Have a look at our animated case study for a good example of this. And thank you for listening. Hi, it's great to have you with us, Dr. Tavidi. Thank you for joining us. Would you mind, firstly, just telling us a little bit about the demographics of your surgery and maybe your diabetes patient?
Hi, Fiona. Thanks very much for having me on. It's great to talk about diabetes. I'm very passionate about diabetes. It's really important we educate as many people as we can. I work in inner city Leicester. I have two separate locations of sites of practice. Our total population is about 8,800, and we have a prevalence of nearly 12% of diabetes. So that's much higher than the national average of 5 to 6%, and much higher than even Leicester's average. So we have at least 1,100 patients with diabetes, of which 90% are type 2 and 10% or less than 10% are type 1, just like everywhere else.
Wow. You're busy then.
Very, yes.
So we know that managing diabetes well initially after diagnosis is really important. How keen are your patients to attend structured education, and how do you encourage them to attend?
So that's a really good question. You know, it's recommended by NICE and everyone that really, as soon as you're diagnosed, one of the first things you should have is structured education. First of all, the diagnosis of diabetes is really difficult to accept. It's almost like breaking bad news and giving bad news. So we have to do it really, really sensitively. But having a tool like having structured education is really important because that helps patients in their journey. It's a bit of a mixed bag. It depends on how we talk to patients. So there are many barriers for them to accept structured education, but I would say about 50% take it up, 50% don't. Most of my patients come from Asian backgrounds, and they worry about language and time and whether they even need it. And some people are in denial, thinking that they know everything, that what's structured education going to do. So I would say about 50% accept it, but we do have work to do there.
How big a part does diet play in the management of type 2 diabetes in the South Asian community?
I think diet is really important. Diet and food brings families together. It's a reason for people to socialize with or without COVID. It's an integral part of culture and also religion. There's certain things you eat. Some people fast. Some people don't eat certain things. So whether it's religious or cultural or social or just even family, diet is extremely important. And this is something that we need to discuss with all of our patients because Asian diets tend to be very heavy in ghee and clarified butter, and also sugar and so on. And so it's really important that we start educating our patients not just about the diet and the constituents, the fats, the carbohydrates, sugars, and so on, but also portion size, because a lot of these patients have come over. Well, I'd say at least 50% have come over from the subcontinent, where they're surrounded by poverty, and and a sign of affluence and doing well is to have a bigger portion, bigger meal, and so on. It's really about educating ourselves that we need to eat for our bodies, not just for our minds.
Oh, right. That's really insightful. Thank you. It can be tricky opening a conversation about weight, can't it? And you've mentioned that we need to be sensitive. How do you open a conversation about weight and about diet? Have you got any tips for us?
Yeah, so one of the things I do is really, really take the guilt away. Most people who are overweight actually know that they're overweight. And, the studies have shown us that actually exercise is really, really important. And fat people who exercise do better than thin people who don't. We've got lots of evidence, particularly from Loughborough University, on that. And so one of the things I say to people is that, look, try and exercise. And I'll say to them, don't worry about losing weight. Just start exercising. Start using a SMART goal. Go for a 10 or 15-minute walk, or even a 5-minute walk. So, the barriers, to all of this are that, women particularly, they tend to be caregivers. They tend to be looking after their children and their mother-in-laws and their family and their job and so on. And they can't put themselves first. They don't find time not only to cook something for themselves, but to exercise. But when I talk about diet and exercise, the first thing I'll try and get somebody to do is to exercise, and just try in small aliquots of exercise. You don't have to go to the gym. You don't need a treadmill. Just go for a 10-minute walk around the corner. People don't realize they can just go for 10 or 15 minutes and then build on that. And my favorite line is, don't worry about losing weight, just exercise. Because then that gives you an entry into talking about weight. Because most people, as I said before, when they're overweight, they know it. And it is a taboo, and it is difficult, because we know that people eat for comfort, out of depression, out of stress. And so we really need to tackle that very sensitively.
Yeah, brilliant. Thank you. That's really helpful. Is there any common themes that you come across? Is there any reasons why people can't exercise or can't put themselves first? You've mentioned that they care for family, and what do you say to people? How do you get around that?
So without being sexist, I do find that women find it very difficult to put themselves first. And it's a men are from Mars, women are from Venus type of thing. Men, if I tell them to exercise, that will be their priority. They will go and they will find time either to go to the gym or go for a run or go for a walk. Women will find 10 excuses before they agree to try and exercise. And so changing behavior, whether it's changing your diet or starting exercise and so on, is a really tricky thing. And it is about prioritizing yourself. Now, it's a very alien thing to be selfish, particularly in all cultures. And I think for women, we tend to be the nurturers that put our children first, do whatever we need to do for our family, and then ourselves. So I think it's in all women, and I've worked in different countries. I found that difference is much more stark than even culturally. When I was working in the States, all the Hispanic women would say, "Oh, you don't know Hispanic men," and the African American would say, "You don't know African American men." And actually, what I realized that women just tend to not put themselves first. And so I do have that conversation with women to say, look, it's really important that you put yourself first. We don't have that. We're not have that wiring. We don't have that mindset of putting ourselves first. You do need to look after yourself. It's a bit like when you go on an airplane and when they tell you the safety things, they say, put your mask on first, then put it on your child. You know, in any other setting, we would look after our child first and then look after ourselves. And I use that example to say, this is why we need to do this in your family. If you look after yourself, your children will imitate what you do. You will exercise better, eat better, and they will follow your example. So it is so important. You know, it's a psychological thing to say to somebody, to say to a woman particularly, put yourself first. It's okay to appear self-centered, but it's important to do that because then your children will learn that. But it's important for you and your health.
That's so helpful. Thank you, and some really great tips there for us all. So thanks so much for all you've shared with us, Dr. Trivedi. That was great. Thank you.
Thank you.